Welcome to the lecture on tumors of the lung and pleura. About 95% of primary tumors of the lung are lung carcinomas, and therefore most of this lecture will focus on lung carcinomas. The other 5% of primary lung tumors include neuroendocrine tumors, sarcomas, lymphomas, benign tumors, and very rarely pulmonary hematomas. This figure shows you the incidence of lung cancer worldwide. The countries marked with red and orange are the countries where lung cancer is commonest. In industrialized nations, lung cancer is the most common cause of cancer-related deaths. And even in Sri Lanka, it is the commonest cause of cancer-related deaths in both sexes, according to Cancer Registry data of 2019. And it is the third commonest cause of cancer among men, and about the 9th commonest cause of cancer in women. Lung carcinomas have a bad prognosis. About 50% of them have distant metastasis at the time of diagnosis. About 25% have regional lymph node metastasis. The overall 5-year survival for all stages of lung cancer is about 16%, which is very low. And even if the tumor is confined to the lungs without metastasis, the 5-year survival is about 45%. So we are talking about a cancer which is quite common, which has a high mortality and poor prognosis. So what do we need to know about lung cancers? At the end of this lecture, you should be able to describe the clinical features of lung carcinoma, list the 4 main histological types of lung carcinoma, and the clinical significance of these 4 types. You should be able to describe the macroscopic and microscopic features of the main types of lung carcinomas and also describe how they spread. Very importantly, you should be able to explain the clinical features of lung cancer based on the pathological changes. And also, you should be able to outline the diagnosis and management of lung carcinoma. The 4 main histologic types of lung carcinoma are squamous cell carcinoma, adenocarcinoma, large cell carcinoma, and small cell carcinoma. Why is it important for us to know these different types of lung cancers? It is because their treatment modalities are different. Earlier, lung cancers were divided into non-small cell carcinomas and small cell carcinomas. This is because the non-small cell carcinomas were managed by surgery primarily, whereas small cell carcinomas were primarily managed by chemotherapy or radiotherapy. But now it is not sufficient to just lump squamous cell carcinoma, adenocarcinoma, and large cell carcinoma into a large group called non-small cell carcinoma, because the treatment modalities for these also differ. Genetic mutations play an important role in the pathogenesis of lung carcinoma. Inactivation of tumor suppressor gene on chromosome 3p is an early event, whereas mutations of TP53, which again is a tumor suppressor gene, and activation of the KRAS occurs relatively late. Adenocarcinomas may show activating mutations in epidermal growth factor receptor gene, and this is important because targeted therapy can be used to block this. EML4 ALK tyrosine kinase fusion genes and c-Met tyrosine kinase genes are also involved in lung carcinoma, but these are not common. Tobacco smoking is the most important etiological factor for lung carcinoma. The risk is about 60 times greater in habitual smokers than non-smokers, and about 11% of smokers may ultimately develop lung carcinoma. So what are the carcinogenic factors present in cigarette smoke? They may include initiators such as polycyclic aromatic hydrocarbon, benzpyrene, and promoters such as phenol derivatives. It's important to remember that passive smoking also increases the risk of lung carcinoma. The risk is increased by about 2 times than in non-smokers. Cessation of smoking decreases the risk, but the risk may not come back to baseline levels. It's also important to remember that smoking of pipes and cigars also increase the risk of lung carcinoma. Other risk factors for lung carcinoma include industrial exposure to radioactive substances like uranium, workers exposed to arsenic, chromium, nickel, vinyl chloride and mustard gas in various industries. Asbestos usually causes mesothelioma, but it can also cause lung carcinoma. And the risk of developing lung cancer is 5-fold for non-smokers and 55 times more for smokers who are also exposed to asbestos. Why is it that some smokers get lung cancer whereas others don't? This may be related to the fact that pro-carcinogens in the cigarette smoke has to be converted to carcinogens by various enzymes. And people who have genetic polymorphisms involving P450 monooxygenase enzyme system may have an increased risk of getting lung cancer. Also, those who have chromosomal breaks on peripheral blood lymphocytes after exposure to tobacco-related carcinogens are more likely to develop lung cancer. As mentioned earlier, the 4 main histological types of lung cancer are squamous cell carcinoma, adenocarcinoma, small cell carcinoma, and large cell carcinoma. Some tumors may have a combination of these. So let's take each histological type and describe the pathological features and the clinical presentation. Squamous cell carcinomas are commoner in males than in females, and it is closely related to tobacco smoking. Several decades ago, squamous cell carcinoma was commoner than adenocarcinoma, but now adenocarcinomas are more commoner than squamous cell carcinomas. Squamous cell carcinomas occur at the hilum of the lung in a major bronchus. It may protrude into the bronchus or may grow into the lung parenchyma, and because it's a malignant tumor, there will be areas of hemorrhage and necrosis resulting in cavitation. How does this squamous cell carcinoma arise in the bronchus? Cigarette smoking causes the respiratory type epithelium to change into a squamous type of epithelium. This is called squamous metaplasia. The squamous epithelium then becomes dysplastic And finally, there may be a carcinoma in situ which involves the full thickness of the epithelium, and then the basement membrane is penetrated and the tumor cells invade the underlying tissue. Although squamous cell carcinoma can be quite locally aggressive, metastasis and extrathoracic spread are late compared to the other types of carcinomas. This figure shows you the gradual development of squamous cell carcinoma. In figure A, you can see the normal respiratory epithelium with the surface cilia. It then undergoes metaplasia to a squamous type of epithelium, which you can see in figure C. You can see that in figure C, the squamous epithelial cells maintain their polarity. They look like normal squamous epithelium. But in figure D, you can see the nuclei are crowded, they are large, they are hyperchromatic. That is an area of high-grade dysplasia. And in figure F, you can see there is haphazard arrangement of these pleomorphic cells within the epithelium. The basement membrane is not penetrated. And this is an example of carcinoma in situ or severe dysplasia. And finally, cells penetrate the basement membrane and invade the underlying tissue, and then it is called a squamous cell carcinoma. These are two examples of squamous cell carcinomas occurring in the hilum of the lung. You can see the large tan-colored tumors with areas of necrosis, and the black areas are areas of hemorrhage. This is another example of a squamous cell carcinoma. You can see the tumor is irregular and infiltrates the surrounding lung tissue and also infiltrates the pleura. This is another example of a squamous cell carcinoma of the lung. Microscopically, squamous cell carcinomas may be well differentiated, moderately differentiated, or poorly differentiated. This figure shows you a well differentiated squamous cell carcinoma where the cancer cells resemble squamous cells because they have intercellular bridges, and you can also see keratin formation, which is shown by the red arrow. Poorly differentiated squamous cell carcinomas are difficult to recognize as squamous cells, and we might have to use specific immunohistochemical markers such as P53 to demonstrate that they are of squamous origin. The moderately differentiated squamous cell carcinomas are in between well differentiated and poorly differentiated squamous cell carcinoma. Adenocarcinoma of the lung is the commonest type that is seen in women and also non-smokers. As opposed to the centrally located squamous cell carcinomas, majority of adenocarcinomas occur peripherally. They may have a central scar of fibrous tissue. Now, unlike squamous cell carcinomas, which do not metastasize commonly, adenocarcinomas may metastasize even if they are very small in size. The precursor stage of adenocarcinoma may be what is called atypical adenomatous hyperplasia, which progresses to adenocarcinoma in situ. This figure shows a peripherally located adenocarcinoma. Microscopically, adenocarcinomas are composed of glandular structures lined by pleomorphic cells, which you see in the figure on the right hand side. Now, the more poorly differentiated adenocarcinomas may not have a lot of glandular structures, and immunohistochemical markers such as TTF1, napsin A, or CK7 may have to be used to recognize these tumors. As opposed to the destructive growths of adenocarcinoma, where the neoplastic glands infiltrate the lung tissue, destroying the normal architecture, in adenocarcinoma in situ, what happens is the cancer starts in the lining cells of the alveolar spaces. It lines the alveolar spaces, and this is called a lepidic growth pattern, the higher magnification of which is seen on the right hand side. Large cell carcinomas are anaplastic, poorly differentiated tumors composed of large cells with pale staining nuclei. These tumors do not show glandular or squamous differentiation. There may be giant cells with bizarre nuclei, mucin-producing cells, or cells with clear cytoplasm. This is an example of a large cell carcinoma. Small cell carcinoma is a very aggressive tumor with a strong relationship to cigarette smoking. Like squamous cell carcinomas, they tend to occur at the hilum of the lung with early involvement of the hilar lymph nodes. Clinically, this is the type of lung cancer that is most commonly associated with ectopic hormone production, which we will discuss later. This figure shows you a small cell carcinoma which is infiltrating the lung tissue from the hilar area, and the hilar lymph nodes are also involved. As the name implies, small cell carcinomas are composed of small cells with scanty cytoplasm and round to oval hyperchromatic nuclei. They may show extensive necrosis. Under the electron microscopy, these tumors show neurosecretory granules, and therefore they are probably of neuroendocrine origin. Immunohistochemically, they are positive for markers such as chromogranin A, neuron-specific enolase, or synaptophysin. Here you can see a small cell carcinoma composed of cells with scanty cytoplasm and hyperchromatic nuclei. How do lung cancers spread? Local spread can lead to involvement of the pleural cavity and the pleura, and in severe cases may even involve the chest wall. Spread will also occur proximally into the main bronchi and the trachea. Lymph node spread will involve the mediastinal lymph nodes at the hilum of the lung, and sometimes the left supraclavicular lymph node is enlarged, and this is called the Verkov's node. Distant spread can occur by lymphatics or by bloodstream, and in the bloodstream they can spread to the other lung, the adrenals, liver, brain, and bone. This figure shows you a liver metastasis of lung cancer. In addition to the pathology of the tumor itself, there may be other secondary pathological features in the lung due to the lung cancer. If the tumor grows into a bronchus causing total obstruction, the distal part of the lung may collapse, and this is called atelectasis. Secretions may collect in the distal part of the lung, can get infected, giving rise to suppurative bronchitis. In long-standing cases, there may be bronchiectasis. If the tumor compresses or invades the superior vena cava, the patient may have what is called superior vena cava obstruction syndrome, where the patient may have engorgement of the neck and upper chest veins, facial edema, and remember, one of the objectives of this lecture is for you to be able to explain the clinical features on a pathological basis. Now, certain symptoms are caused directly by the tumor. For example, when the tumor erodes into the bronchus, it will give rise to cough. If it erodes into a blood vessel, the patient may cough out blood. If the tumor obstructs the bronchus, the secretions in the distal part may get inflamed, giving rise to a pneumonia, and so the patient may present with symptoms of pneumonia. And we mentioned about superior vena cava obstruction. As a general feature of the cancer, the patient can have cachexia, giving rise to anorexia and weight loss. Involvement of the left supraclavicular lymph node may give rise to swelling in the left supraclavicular fossa. This node is called the Virchow's node, as I explained to you earlier on. If the tumor is at the apex of the lung and if it involves the brachial plexus, there may be pain in the distribution of the ulnar nerve. Also, apical tumors may involve the sympathetic chain, giving rise to Horner's syndrome, where the patient may have ipsilateral enophthalmos, ptosis, miosis, which is constriction of the pupil on that side, and anhidrosis. An important group of symptoms caused by lung carcinomas include paraneoplastic syndromes. Paraneoplastic syndromes are a group of symptoms which are not due to the local effects of the tumor nor due to the metastatic deposits of the tumor. The commonest cause for paraneoplastic syndrome are production of hormones and hormone-like factors. For example, production of antidiuretic hormone may cause hyponatremia, ACTH may cause Cushing syndrome, secretion of parathormone may give rise to hypercalcemia, all the symptoms of hypercalcemia. Calcitonin production may give rise to hypocalcemia. Sometimes these tumors produce sex hormones or gonadotrophins, giving rise to gynecomastia. And if they produce a hormone called serotonin, it can give rise to carcinoid syndrome. In addition to ectopic hormone production, other paraneoplastic syndromes caused by lung cancer include muscular and sensory defects, like they may have a myasthenia-like syndrome, which is called the Lambert-Eaton myasthenic syndrome. They can have peripheral neuropathy. They can have various skin lesions, which I will show you in a little while, like acanthosis nigricans. They may have abnormalities in peripheral blood. Sometimes the white cell counts may be very high. That is called a leukemoid reaction. They may have swelling of the ankles and wrists in a condition called hypertrophic pulmonary osteoarthropathy. They can also have various coagulation abnormalities, giving rise to migratory thrombophlebitis, non-bacterial endocarditis, and disseminated intravascular coagulation. These are examples of acanthosis nigricans, hypertrophic pulmonary osteoarthropathy, Most of the paraneoplastic syndromes are caused by small cell carcinomas. For example, ACTH production and ADH production is caused by small cell carcinoma. Hypercalcemia may be caused by small cell carcinomas or squamous cell carcinomas. Carcinoid syndrome is caused by a different group of tumors called neuroendocrine tumors, and the so-called bronchial carcinoid tumor belongs to this group of neuroendocrine tumors. The diagnosis and treatment of lung carcinoma will be dealt with in another lecture, so I will not go into details. Initially, the tumor mass may be recognized by a chest X-ray and maybe a CT chest. And then in the histology laboratory, it is possible to examine the sputum for malignant cells, especially in the case of a hilar tumor where the malignant cells have got into the bronchial tree. And if this is so, we could also obtain some material from a bronchoscope where we can either brush the epithelial cells or we may inject some saline and take a washing from the bronchial tree. And treatment consists of surgery, radiotherapy and chemotherapy. I will not go into details in this lecture. Like all other carcinomas, lung carcinoma is staged according to the TNM staging, where T stands for tumor size, N for lymph node status, and M for metastasis. Lymphangitis carcinomatosis is a specific way of transmission in the surface lymphatics of the lung, and as a result of this you can see a network of whitish lymphatic channels on the surface of the pleura. These are the lymphatics which have been involved by the carcinoma, and this is called lymphangitis carcinomatosis. Let's now discuss a little bit about tumors of the pleura. Most tumors of the pleura are metastatic deposits, and primary pleural tumors are not common. Primary tumors of the pleura may be benign tumors like solitary fibrous tumor. The commonest malignant tumor of the pleura is called malignant mesothelioma. You need not know a lot about solitary fibrous tumors. They are small localized tumors attached to the pleural surface, sometimes by a pedicle. They are composed of dense fibrous tissue, and sometimes there may be cyst filled with fluid. Microscopically, the tumor is composed of spindle-shaped cells resembling fibroblasts and reticulin and collagen. Mesothelioma is the commonest malignant tumor of the pleura. It may arise either from the visceral or the parietal pleura, and the most important etiological factor for malignant mesothelioma is asbestos. Asbestos bodies have been found in increased numbers in the lungs of patients with mesothelioma. A characteristic growth pattern of the malignant mesothelioma is that it involves large areas or the entire pleural surface, so that the lung is ensheathed by a thick layer of soft, gelatinous, pinkish tumor tissue. Microscopically, the mesothelial cells have the ability to either differentiate into epithelial-like cells or mesenchymal stromal cells, which are spindle-shaped cells. Here you see a malignant mesothelioma which is ensheathing the lung, which is seen in the center as a brown colored area. Microscopically, as I mentioned earlier, if the tumor shows a mesenchymal differentiation, then it will be composed more of spindle cell shaped, resembling a sarcoma, and therefore then it is called a sarcomatoid type. If it is epithelial predominant, then the tumor may show glandular or papillary structures which are lined by cuboidal or columnar cells. Because the tumor ensheaths the lung and the lung cannot expand, patient may present with dyspnea. Sometimes they may present with chest pain, and because the pleura is involved, they may also present with a pleural effusion. About 50% of patients with pleural disease die within 12 months. A few survive longer than 2 years. How do mesotheliomas spread? The lung may be invaded directly. Metastatic spread occurs to the hilar lymph nodes and the liver. It's also important to remember that pleura is not the only site for development of mesotheliomas, because mesothelial cells also coat the peritoneum, pericardium, and tunica vaginalis. They may also arise in the genital tract. So to summarize, you should now be able to describe how patients present with lung carcinomas. You should be able to describe the clinical features of lung carcinoma. The 4 main histological types of lung carcinomas are the squamous cell carcinomas, the adenocarcinomas, the small cell carcinomas, and the large cell carcinomas. You should be able to briefly describe the macroscopic features of these tumors. Squamous cell carcinomas and small cell carcinomas tend to be central hilar tumors, whereas adenocarcinomas are usually at the periphery. You should be able to explain the clinical features of lung carcinoma based on a pathological basis. And you should also be able to outline the diagnosis and management of lung